Good morning, everybody. Thank you so much for joining us today for our Global Neuroscience Grand Rounds. For those of you that have been here before, I'm a new face. Hi, I'm Dr. Jill Farmer. I'm the director of the Movement Disorder Program with Global Neuroscience Institute, and I'm filling in for Dr. Glebus, who you usually see. With that, I have the absolute pleasure of introducing our speaker today, Andy Lovell. Andy Lovell is the Emergency Medical Services Chief since 2007 in Gloucester County, New Jersey. In his tenure, he restructured the operational plan and budget for implementation of the first county-based EMS agency in New Jersey. He currently oversees operation in 22 participating municipalities, utilizing 14 stations, 250 staff members, and a fleet of 35 vehicles. He's been presented with the Administrator of the Year Award multiple times. He has negotiated and implemented interlocal service agreements with multiple municipalities. He's the paramedic representative to the New Jersey EMS Council. He's the representative on the Southern New Jersey Medical Coordination Center. He's the chairman of the New Jersey EMS Council and EMS BLS Operations Subcommittee, and is a member of multiple advisory committees and task force, including the EMS Task Force, County EMS Coordinations Committee, International Association of EMS Chiefs, National EMS Management Association. He's been recognized for his expertise in customer service, and he is a prominent speaker for numerous EMS conferences. And it is our great pleasure to have him not just speak today, but be a member of the GNI team in our commitment to stroke care throughout New Jersey. So without further ado, I invite you to start your video and share your screen, and I will hop off. Thank you so much.
So good morning, everybody. I'm playing without a net here on Zoom for the first time. So welcome to Gloucester County EMS, and welcome to South Jersey, where it's pouring at the moment. So I'm afraid that's probably part of what the rest of you are all gonna see later on today. And just before we get started, just a personal thanks from me to everything that you do for our joint patients out there. I've been an EMS provider here in the state of New Jersey for more than a few years, since before my hair was this color, actually. And collectively, we have seen such a change in the interventions and the outcome of our patients throughout my career. You know, our neurological patients, I'm sorry, we went from initially those folks kind of got unfortunately sent to the back of the ER and admitted to a floor, and then ultimately discharged to long-term care with no real change in their presentation. And now some of those same patients, thanks to you guys, we actually see walk out of the hospital deficit free. So just a personal thanks from me and from all the pre-hospital folks here. So again, my name is Andy Lovell. Been a paramedic a long time over here, Chief of Gloucester County EMS, and I have absolutely no disclosures other than I am a very outspoken advocate for tremendous and outstanding pre-hospital care. So I'll tell you a little bit about Gloucester County EMS real quick, just to give you an idea where we come from. We're actually up to about 300 providers right now. 299 of them are just the absolute best folks I've ever had the opportunity to serve alongside them. And then there's the one old gray-haired guy who leads from the bottom of that agency. In New Jersey, we operate what's called a two-tiered EMS system. So the BLS is typically provided by a local agency of some type. In New Jersey, all of our ALS is provided on a certificate of need basis. And all those certificates of need are tied to acute care hospitals. So it means that our ALS providers see nothing but ALS patients. So I will unashamedly tell you, some of the best paramedics on the planet are here in the state of New Jersey. Now, with that being said, even though we're a BLS agency, because we're a public agency, because we have, at least I think, a great educational model, good benefits, and a good clinical model, we actually have a lot of paramedics and paramedic students that work for us full-time and then work other places per diem. Even myself work per diem as a paramedic. And as Dr. Farmer indicated, we're the first county-based EMS system in the state of New Jersey. Sometimes it's not always best to be the first, but we are definitely the first system here. And in New Jersey, we are ashamedly the home of the castle of home rule, which means every town has its own everything. So it's taken us a little while to figure out what most of the rest of the country does, which is to deliver services on a larger basis rather than on an individual municipality. So we are the first county-based system in the state of New Jersey. That's our coverage area right there. Everything in green is what we cover. The two last municipalities, candidly, I will tell you that before I retire, I'm sure that they will come on board with us also. We started back in 2007 serving 10 municipalities. We now serve 22 of the 24 municipalities here in the county of Gloucester. And I would say that one of those two that's remaining will join us next year, and the other one will join us the following year in 2023. To kind of give you a geographical perspective, if you look at the upper left part of your screen, Logan, Greenwich, Woolwich, Paulsboro, that area there, that actually borders the Delaware River. The Commodore Barry Bridge lands on our side of the river right there in Logan Township. So when we go over the Commodore Barry Bridge into Delaware County, Pennsylvania, that drops us right into the backyard of our great friends over there at GNI. So that's the relationship between us. We transport patients over there every day. We serve about 290,000 folks, and that's about 338 square miles of coverage. So EMS agencies, when they make staffing and deployment plans, have to take two things into consideration. The first thing that they have to take into consideration is what they anticipate the call volume to be. So that's that's staffing for volume. Because we're a mix of suburban to rural and agricultural area in some of our coverage area, we actually have to staff for distances. So it's not so much the volume of calls that are going to come, it's the geographical distances we have to cover, the time it's going to take us to get there. So we'll respond to about 35,000 calls. Just about 400 of those will be triaged as a stroke this in 2021. We'll talk a little bit later, but our call volume, took a pretty significant nosedive in the front end of the pandemic. We had lots of folks that weren't calling 911 that candidly should have, and they're the same folks that you would see in your clinical roles several days past when ideally they would have sought treatment. Because we're a middle-sized EMS agency, we have a lot of specialty resources over here that are not necessarily available in other areas. Based on the trying to say this tactfully, the girth of our population, and it's continuing to increase. We actually have 3 bariatric ambulances stationed throughout our coverage area. It's not unusual for at least one of those to be deployed at all times anymore. And frequently we'll have as many as 2 of them, and occasionally even all 3 of them deployed for those folks that exceed that 450-pound weight number, and that we really need specialized resources for that. We also have an off-road ambulance that we utilize along the river and some of our parks and some outdoor festivals and stuff like that we provide coverage for municipalities on. And when I say off-road, if you think of I'm sure you're familiar with a Gator. It's almost like a Gator vehicle with an enclosed an air-conditioned patient compartment on it. We use it at the community festivals because it actually gets through crowds and things a little quicker. And then we also use it occasionally when we have to go retrieve somebody who's back in the woods or some other area. We also have a multi-patient ambulance bus. We're actually about to add a second one of those down here. And what we're exceptionally proud of here is our EMS training academy. One of the few agencies, we kind of took a cue from a place called Mount Laurel EMS up in Burlington County, where we have our own in-house training academy. So we actually can bring folks in that are untrained, put them through our academy. We don't charge them, obviously, for the academy, unlike other places. And then if they're successful at the end of the academy, we bring them on as employees. So whereas a lot of training facilities are training people to obtain that initial EMT certification. The goal of our training academy actually is, and it's a one-year program, so it's much longer than most other programs, is to have you to the point when you graduate and complete your externship with us, you can flip right over and become an employee. And our goal is to keep you here for, throughout your entire EMS career. So what is the role of EMS in stroke care, and where do we fit into the chain, the stroke care chain? So early notification is certainly something that we're a part of here. We actually dispatch all of the, we're the public safety answering point for all the 911 calls within the county of Gloucester. So we not only answer those calls, but we dispatch all EMS, fire, and police resources, not only, believe it or not, within the entire county of Gloucester, but we picked up, I think it's a half a dozen municipalities within the top end of Atlantic County, because they don't have a countywide dispatch system like what we do. So we dispatch resources within and outside of the county of Gloucester. We'll answer about 125,000 911 calls. And the question you may ask yourself is, if we're answering 125,000 calls, why are EMS calls only about 35,000 of that 125,000? So the overwhelming majority of 911 calls we receive are for police resources. And then particularly more so in the EMS and fire resources, if it's a public incident. So for instance, it's a motor vehicle accident out on the highway, we may get as many as 24 911 calls for the same incident. So that's why those numbers seem kind of out of proportion, but they're actually not, because most of those, or a lot of those calls, there's actually a duplication of the call. The other challenging thing for our dispatchers is that the bulk of 911 calls now come in on cell phones. So if you dial 911 from a landline, when your call comes into us, not only does the phone number you're going to calling from come in, the geographical location of where that landline comes in, and the name that phone is registered in. So if it's, XYZ business, it'll come up as XYZ business with the address and the phone number that you're calling from. With next generation of 911, for the cell phones, we now get the cell phone number that you're calling from, as well as the geographical coordinates, and the geographical coordinates then are plotted on a map to give us a physical address. So it makes it a little more challenging, so to speak, for us, I guess, or challenging for our dispatchers. But the technology continues to improve for that. So the call triage process, how do we do that? We have a set of what are called guide cards here in New Jersey that all public safety answering points utilize to determine what's going on, where it is, what resources are needed. And this is the initial guide card that everybody who calls 911 gets asked the following questions. And this determines on a medical call. You see it's a flow chart, and then there are additional flow charts that come off of this based on what the chief complaint is. So this is the initial call, and this is what the dispatchers triage the calls to determine, essentially immediately determine the acuity and where the next guide card is going to be. This is the call that's utilized, or the card, I'm sorry, that's utilized here in New Jersey for stroke, trying to tease out the stroke symptoms. Obviously, there's a lot more subtle presentations of stroke that are not going to be encompassed by this card. But this is why, out of those 35,000, we're teasing out 400 of them on the initial dispatch that it's potentially a stroke patient. You'll also notice down at the lower left-hand corner of the card, when we talked about ALS or BLS, obviously 100% of the dispatches get a BLS agency like us. Those higher acuity calls get a simultaneous ALS dispatch, again, separate agency. And this is what helps the dispatcher make that determination of whether he's sending ALS and BLS or simply sending BLS. In addition to that, There's pre-arrival instructions that are given to the caller. So these are kind of some of the things that we're asking folks to do prior to EMS's arrival. And again, for every complaint, you'll see a card just like this, or you won't see it, but it's available in dispatch. When I first started, believe it or not, these were flip cards. Obviously, it's all electronic today, and it's tied to the CAD system so that as the dispatcher is selecting the card that he's going to utilize, the dispatcher that's actually going to send the call out, those pieces of information are being populated in front of him or her as well based on the card that's selected. So again, those are all things that are used to save time. So some calls really are straightforward. Sometimes they're incredibly difficult to figure out what's going on. I've never been a dispatcher, and I have to give all the credit that is due to dispatchers everywhere, because they have to do within 60 seconds of the 911 call ringing and getting answered. They have to figure out what's going on, where it's going on, the appropriate agency to be dispatched, and then dispatched. And they're going to do all that in 60 seconds, which sometimes is very challenging. So some of the calls are really straightforward. And I'm going to give you a couple of 911 calls here real quick just to listen to.
911, where's emergency?
Yes, hi. My mom is very lethargic and she's not feeling too well.
Okay, you're in Franklin Township?
We are, yes.
What's the phone number you're calling from now? How old is she?
She's 81.
Okay, what kind of medical history does she have? Heart problems, anything like that, diabetes?
No diabetes. She has high blood pressure, and for the heart, I think she had like a
MI?
Yeah, like
That's all right. You said she's lethargic right now, though?
yeah.
Okay, has she been like this? Just come on all of a sudden, or she like this all day?
Yeah, she seems swollen and stuff too. Yeah.
Where at her legs, or just all
Her face, like her face looks so swollen.
Okay,
AFib, that's what it was. Yeah.
okay. All right. I mean, is she speaking to you or no?
Yes, yeah, she is. Yeah.
Does she have any slurred speech or anything like that, or?
A little bit, yes.
This never happened to her before?
She, before when she had, they had put her on a seizure medication, and it threw her for a loop before.
Okay, but has she ever had a seizure before, or?
No, she never really had a seizure, no.
Okay, and what's your last name? Okay, just have her rest as comfortably as possible, get her medications together. Okay, if she takes any, if you have a list, that's fine too, and we'll have somebody out there. We'll have somebody out there for you.
Okay, thank you so much. Appreciate it.
You're welcome. Bye-bye.
All right, bye-bye.
So as you can see, even on some of the straightforward stuff, it takes a while to tease that information out of the caller. It's what's called caller interrogation, actually, which sounds like a harsh term. But that dispatcher is going by that guide card. And by the time he is teased out of her, their speech is slurred, he's already sent that call over to be dispatched as a stroke. And that's a call from just the other day. The reason it sounds kind of choppy is obviously it was redacted. I had to pull out all the readily identifiable information, the phone number, the location where the call was coming from, etc. Those tones that you hear coming over at the beginning, that's the data coming from the phone company that's pushing over that information we talked about, which was the location of the call, the caller's name, and I'm sorry, not the caller's name, the person whose the phone is registered in, and the phone number itself. Interestingly, if just as background information for you, if in most jurisdictions, if you dial from a landline and you dial 9 and the number 1 and then hang up, so you don't dial 911, you dial 9 and 1. When you hit that second 1, that's when that data comes over to us. And even if you hang up after dialing 9 and 1 within our jurisdiction, you're going to get a police response just to make sure that everything's okay. So those are called abandoned 911 calls, and we don't, but law enforcement, we always get a law enforcement response to that as well. A lot of PSAPs will call you back, and if you say everything's okay and nothing sounds out of the ordinary, then they'll cancel that police response for you. but that's the level of sophistication with the country's 911 system. I'm going to play for you another call, just came in also from the other day. Again, the information's redacted out of it, but you'll see, and it's a little disturbing, and I apologize if this bothers anybody, but you'll hear how difficult it is. And again, this is why I give all the credit in the world to the dispatchers on how hard they have to work sometimes to be able to do their job, to be able to dispatch the appropriate resources.
I'm home emergency. Hello. Okay, what's the address? What's the address? Who is shot? Okay. Okay, where was he shot at? Okay, I know in the house, but where at? On his body? I understand. Then you need to listen to me then so I can help you, okay? Where is he shot at on his body? I couldn't see him in the middle of the combat. Okay. Is he breathing? I don't know. Mommy, is he breathing? Listen to me, okay? Stop yelling. I understand you're upset, okay? But we need to help him, okay? So you need to gather your stuff together. I need you to go over to where he is and see if he is breathing or not. I understand that. I understand that, but you need to do this for your father, okay?
So resources have already been dispatched at this point because of the gunshot and the fact that the patient's not breathing.
Ma'am.
I'm sorry, my mom's on the phone with the police as well.
I understand. She's on the phone with my partner, and she's not giving him any information, okay? I need to get some information from you, okay? Was he shot? Did he do it himself?
No, he did not. He was shot at.
Okay, he was shot at by who?
My brother.
So where is your brother at?
My brother is in the house.
Okay, where is the gun at?
Where's the gun, Christian?
Where's the gun at?
I think he still has it.
Okay, I need everybody to get out of the house, okay? Get out of the house. All right? What did he use? Do you know? Was it a shotgun, a handgun?
I'm scared.
I understand that.
He told me to go outside the house.
The police are...
Outside the house. He told me to go outside. He told me to go outside.
Son shot the father. Son's still in the house and has the gun. Trying to get everybody out of the house.
You need to call me.
I have to go. Mommy. Mommy, I have to go.
Ma'am, where's your mom at?
So, and that goes on for a while, but you can see how challenging that is for the dispatcher. And while the dispatcher sounds harsh, he's trying to ascertain if those folks on scene are safe. He doesn't want to send responders into a situation where they'll be in danger. So, and that was a very unfortunate situation. But because the dispatcher did the appropriate thing and then instructed the rest of the folks to get out of the house, other than the initial shooting, there were no additional injuries on scene, and all of the response agencies followed their appropriate role to prevent themselves from getting hurt while they took care of the patient that was there. So once the dispatchers have grabbed that information, we actually send the calls out to the response agencies in multiple different fashions. And I would tell you that most PSAPs throughout the country do this as well as what we do. We send the call out over the radio and over the audio pagers, just as we've done for 50 years. But in addition to that, all of our vehicles and all of our stations actually have a screen for the CAD, which is a computer-aided dispatch. They have that, we have that in all of our stations and in our vehicles. So we will see the same information that the dispatcher sees, and that'll pop up and actually those electronic updates come quicker than what the radio notification does. So if I happen to be in my ambulance or in the station and I'm looking at the screen, I'll actually see that call populate on the screen. A big box will open up with the information and it flashes red, so it gets my attention, and I hit acknowledge. Once I hit acknowledge, then it displays for the location that I'm going to. And then I can actually change my status from the vehicle without even talking to the dispatcher on the radio if I want to go that route. In other words, I can put us en route, I can put us arriving on location, I can put us en route to the hospital, select the hospital that we're going to, and arrive us at the hospital. Why do we do that? It cuts down on the amount of radio traffic, so the data we collect is a little more accurate. There's less of a chance of making an error because multiple agencies are trying to talk on the radio at the same time. And because we're pushing that data out electronically, there's some third-party applications that are out there a lot of our guys use, so they'll actually get notified of the call on their smartphone. We certainly send it electronically to the crew's smartphone, and then beyond that, we also send it as an email directly to the email account that's sitting running in the background on our station computers also. So if you don't happen to be looking at the CAD screen, but you happen to be looking at the email screen, you'll see it pop up there as well. The other reason that we do it in so many different fashions is it gives us obviously redundancy. The last thing in the world on an essential service like us, and you guys do this all in your clinical roles as well, we never want to rely on just one source of notification. If we did that and then that source failed, now we wouldn't be available for the public. And that's just a picture of a pager that I'm sure everybody has seen. And if you spend any time in the ER, I'm sure you've heard them going off as well for those EMS agencies that are in your ER. So rapid response, we've been doing time-sensitive responses. We as an industry have been doing time-sensitive responses forever. The gold standard that we all try and meet is to be on scene in less than 9 minutes, 90% of the time, called the 9 in 90 standard. Why only 90% of the time? If you think back to that great big map of Gloucester County and you get down into some of our more rural areas such as Elk Township or Franklin Township, there are sections there where there are candidly very, very few residences. In order to make it 100%, you know, from an economic a service platform and delivery platform model, we can't station enough vehicles within 9 minutes of some of those really, really rural areas that they could be there. Those crews might have a call every month kind of thing. So that's where that 9 in 90 piece comes from. Clinically, we've learned over time that that 9 in 90 standard doesn't make a difference in patient outcomes. There's a very, very small percentage of our calls where the time truly is of the essence there and going to make a difference in the clinical outcome, and certainly neurological cases fall into that catchment. So we're looking at, we as an industry have been moving away from the 9 in 90 standard to stratifying the calls, and for the highest acuity calls or potentially the highest acuity calls, actually pushing that response time standard up to 6 minutes. So what are some of the challenges that we see here in the field of EMS right now? Same thing you guys are facing, I'm sure, in your clinical settings, staffing. It has become a daily challenge for us here. We work in an industry where typically there'd be between a 22 and 24% turnover every year. And that's not to say, don't in any way walk away from that thinking that that's because EMS is not a profession that people want to participate in. It's actually absolutely the opposite. Lots of folks that come into the world of the EMS and use that then as the launching point for their healthcare career. I know lots and lots of great acute care nurses, certainly physicians, trauma surgeons, et cetera, started their career way back when in EMS. And I think it certainly gives you a tremendous perspective on what happens to patients before they hit the door of the ER, The other point of it, candidly, is as our physician friends will be aware, there's some medical schools now that are forcing folks to become EMTs in their first semester or first quarter. Great idea. Obviously, I'm biased, but it's a great idea because now if these folks go out and are laying their hands on patients and learning the basic assessment skills, they're also learning whether or not they hate their fellow man. I would hate to go to medical school, spend all that time and all that money only to find out that it wasn't really the career for me dealing with people. So that help or doesn't help. That's part of the reason for some of the turnover that we see. Additionally, beyond that, the COVID has hit. It's kind of turned us all around. And this is not staffing is not just a Jersey problem or a tri-state area problem. This is a nationwide problem that we're all dealing with. We're faced with the same challenges that came out of COVID, which was that for the better part of a year, we shut down all of the training programs. Ours was the only training academy in New Jersey still operating, believe it or not, at the height of the pandemic. So if you take an industry where you have a 25% turnover per year and you shut training off for a year, you lost 25% of your providers with nobody else in the pipeline to bring them in. Same shortages that I'm sure you've seen in the clinical settings from shutting down the nursing training programs, et cetera, during the height of all of that. The solution that is being utilized, we're not using it here yet, thankfully, knock on wood, but a lot of EMS agencies are putting mandatory overtime onto their folks. The downside of that obviously is that we're burning those folks out quicker and quicker. Some of our hospital-based systems are paying huge bonuses for EMTs and paramedics to take extra shifts. I'd be happy to show you my smartphone and show you from the agency that I work at, the triple bonus shifts that are being paged out every day. Amazingly, I can make $114 an hour to go work as a paramedic if I pick up an extra shift on the weekend. Great for the short term, not financially sustainable in the long term. And candidly, the question we have to ask ourselves as EMS administrators is, are we burning those folks out quicker because we're putting those extra, allowing them to pick up those extra hours? The other challenge that we face is our call volume is now back up to where it was before COVID, and actually surging past that. So throughout the industry, we're taking a look at how we're going to potentially divert some of those low or no acuity calls to other service platforms. One of the things we're looking at here in Gloucester County, we see EMS, as you're aware, is the safety net for the public. If Mrs. Smith has slipped off the chair and fallen on the floor, if you pick up the phone and dial 911, you'll get an ambulance. And those folks in the ambulance will come in and help Mrs. Smith up off the floor, do a quick assessment, determine if she needs to go to the hospital. In most cases, they're asking us not to go to the hospital. They're just calling for assistance. And they're calling because they don't have another alternative to that. Or we get calls every day for folks that need help getting a family member out of the house and into the passenger seat of a car to go to a medical appointment. And then when they come home again, we're helping those folks back out of the car and back into their home. It's a very much needed service. Obviously, there's no reimbursement that follows that. So that's just part of the community service we provide. But it's tying up a crew for that 20, 30 minutes that it takes to do that. So one of the things we're looking at across the industry, other EMS agencies are looking at, is how can we deliver that service or without tying up an ambulance. In our particular case, we're partnering with some of the fire agencies, the career fire agencies within our coverage area. And at those times when our call volume begins to peak and our available units are starting to dwindle, we're going to hand off some of those to some of these partner agencies, so that the resident gets the service that they're looking for, but we still have reserve units available for the higher acuity patients that are calling during those time periods. Here in New Jersey, we've had some what are called staffing waivers that came down from OEMS. That's the agency that the Office of Emergency Medical Service, State Department of Health, that oversees us and every other licensed EMS agency here in the state of New Jersey. One of the things that they've done for us is allow us to, rather than the paramedic unit having 2 paramedics on there, we'll take a paramedic and staff it with an EMT. Rather than having 2 EMTs on an ambulance, we'll have an EMT and a first responder who's certified in CPR. We haven't taken advantage of any of those waivers here yet because thankfully we've had adequate staffing. I think particularly in the commercial side of the business, what we refer to as transport EMS agencies, a lot of them here in New Jersey have been very successful at utilizing first responders and EMTs to staff their ambulances to keep them in service so that they can handle the hospital discharges, so that the hospitals now have beds available to admit patients to. And all of that is based on this call volume surge that we're all experiencing. It's a really bad combination if you think about it. Staffing going down, call volume going up. Not a good combination for our industry, and certainly not a good combination for our patients. And then there's COVID. This is one of the things that you deal with every day and we deal with every day, and it's really starting to, the provider fatigue that you see in your staff is the same fatigue that we see here. We have PPE utilization and disinfection mandates. Those are all, obviously we don't, I'm in no way saying that those are not needed, but imagine applying those into a mobile environment, which is what EMS is all about. The other challenge we face is we're pretty far down sometimes on the supply chain. We don't have the bargaining power of a healthcare system when we go out and create contracts, not only for the cost of the PPE and supplies, but what our priority is versus some of the other larger customers. So that's become challenging for most EMS agencies as well. So how do we, once we arrive on scene, what do we, how do we assess that patient? How do we determine what the appropriate destination is for that patient? So we've had a number of neurological assessment tools that have evolved over time. Most of you, I'm sure, are aware of it. Cincinnati Prehospital Stroke Scale, that's the big one that everybody has, or most EMS agencies have been used, certainly part of the initial training of every EMS provider. Good at teasing out whether or not potentially the patient is experiencing a neurological event, not really good at teasing out the severity of that event. Same with the Los Angeles Prehospital Stroke Scale, a little better at that, but again, not really definitive for what we're looking for. The Miami tool is the MEND scale, same kind of thing. So in New Jersey and throughout a lot of EMS, within New Jersey, we are forcing every EMS provider, gently encouraging, but forcing every EMS provider to use the RACE scale. We actually have statute that will come down once that training is done, that all EMS providers and all EMS agencies must use the RACE scale. And the idea behind the RACE scale is that if it's 4 or more, they should go to an LVO center, a large vessel occlusion center. As we have more and more of those now available, we're trying to assist in getting the right patient to the right destination. And while that sounds easy, I'm sorry, last one, our folks in neurology are very, very, very familiar with it. National Institute of Health, great scale, very, very difficult for EMS providers to utilize because we don't do it every day. We don't do it with every patient. So that's why RACE has become the standard here in New Jersey, and looks like it probably will be the standard throughout the country. Sometimes we have difficulty determining and being able to get to you that last known well time. For folks that have family and friends, they always want to tell us, and you face the same challenges when they noticed it, and have difficulty understanding when we're talking about the last time we knew them to be well or what they didn't have it. COVID has added some challenges to that, because a lot of times, particularly during the height of the pandemic, that coworker or that family member can't accompany that patient to the hospital. So we make a huge, huge, huge effort to make sure that we get a cell phone number, not a landline number, but a cell phone number for that person, so we can hand that phone number off. We use a lot of subtle on-scene clues to try and figure out when we have a patient who's by themselves, when this may or may not have started. If we can find out from the neighbor when the mail gets picked up, is the mail still sitting there in the mailbox? Are there dirty dishes in the sink? Does the bed look like it's been slept in? All of those kind of things to try and narrow that down to when that last known well time may have been. Some of the challenges that we face on scene, it's, if you want to make a hero, make yourself a hero to an EMS provider. When somebody explains to you how difficult a time they had getting the patient out of their environment and to the ER, just listen to what they have to say, because some of the stories you'll hear are just unbelievable. So we talk about the need or the work we sometimes go through to extricate the patient from the incident location. 99% of the time, believe it or not, we're not talking about motor vehicle accidents. We're talking about somebody out of their residence, and the patient's weight and their living conditions. Folks that are on scene that are trying their best to help us, but really are sometimes, unfortunately, slowing the process down. These are all the challenges that we face. Hoarder situation, believe it or not, a frequent challenge that all EMS agencies run through. And you have to sometimes recognize that while this looks like rubble to us, if we pick this stuff up and start pitching it out of the way, we're going to cause additional stress on our patient, because this is the way that they've chosen to live. And obviously we'd all agree that there's probably some mental health challenges going on here, but it's not our place to make a judgment. Other physical challenges sometimes that we face, first rule in EMS, the larger the patient is, they're going to be on the second floor in the back bedroom, which is going to be kind of tough to get out of. Typical kind of small staircase we'll find in an older home that comes down, makes a left-hand turn, and then continues down the steps. Patients unconscious, patients unable to assist in their own extrication. Imagine the challenges that we face with this. Same thing, even sometimes outside with very ornamental, nice looking staircase. You'll notice the mold on it. The moment it rains, that becomes very, very slippery for the providers trying to bring that patient out, whether it's on a flexible stretcher, whether it's on a stair chair, that kind of thing. ED, once we've got the patient in the ambulance, trying to determine the right ER to take that patient to. Primary versus comprehensive stroke center. Every hospital in New Jersey now is state accredited to be a primary stroke center. We have a group of them that are obviously able to make interventions that are comprehensive stroke centers. Some of the non-medical challenges that we face, believe it or not, here in New Jersey, we have politics, and politics has invaded everything. So catchment politics becomes something that we need to deal with every day when trying to make the appropriate destination decision for our patient. And I personally would say that we're in the same place that we were 20 years ago with STEMIs. We had a big debate going whether they should go to a non-cath lab facility to get dripped and then shipped someplace else that actually was able to do the intervention. We finally put that argument to bed and recognize that we should be going directly to the interventional centers. A real challenge that we face today is turnaround time. Staffing in ERs is just as critical as it is here out on the street. ERs face the same challenges of having beds for the patients and having staff to staff those beds. And whereas our typical turnaround time used to be 20 minutes for us, for most of the facilities that we go to, there are times we just had a turnaround the other day that was more than 2 hours. So not the patient's fault, not the ED's fault, but the system, pre-hospital and in a hospital, certainly our fault that we're not returning those units to service in a timely fashion, or figuring out a way to return those units in a timely fashion. Lots of work going on our end with our partner hospitals here, and some kind of unique things that we're going to try out very quickly to determine if we can work on shaving that time without forcing all of the responsibility onto the ED. We reach out and notify the receiving facility. Similar to other patient presentation, we'll pick the phone up, make a phone call. There are some smartphone apps out there that'll do it for us. Triage and Pulsera are the biggest ones. The interesting thing about those apps is that within the facility, within the receiving facility, you can steer those notifications to the appropriate on-call specialist and change that each day. So it's great. They do some other nice stuff that can minimize some of the door to intervention time by pre-registering the patient prior to them hitting your door. The downside is that different healthcare systems use different apps, and there's always a cost to that. And most of the cost is borne by the healthcare system. And telemedicine is a new movement in our area. We'll talk about a little bit more about that very shortly. Some of the things that really work, that we've noticed that work phenomenally in terms of getting the patient to CT or whatever the intervention is quicker, or assessment tool is quicker. A lot of EDs that we go to now, particularly with neurological patients, and if they are, as I say, that all of them are now primaries at a minimum, many of them are now becoming comprehensive, is have the physician greet the patient while they're still on the EMS stretcher, make the determination whether or not that patient then is going to go straight to CT. Some places will obviously send an EDRN or the patient's RN down there along with an ED stretcher. So once a patient comes off the scanner, they can go right into the ED stretcher and return. Some of the facilities that we work with are now having if they have a teleneurologist, obviously on their cart, so to speak, that'll go with the patient now to the scanner as well. And certainly the ED, neuro ED over at Crozier saves tremendous amounts of time and really helps, I think, personal opinion, certainly leads to better patient outcomes. So where there's some opportunities for collaboration between pre-hospital and in-hospital, certainly closing the loop on patient outcome is tremendous. It's one of the most frustrating things as an EMS provider is whether or not you're in the loop on what your patient outcome was and how your intervention may or may not have assisted that patient. So receiving that feedback from the receiving facility is tremendous. Biggest challenge there is making sure that we have up-to-date contact information, or you guys have up-to-date contact information on us. Educational outreach, nothing creates an impression with these neuro patients, especially that have undergone interventions, is taking a look at the pre and post CTA for those patients. That drives home that point for EMS providers about what is actually going on and the absolute importance of timely intervention for that. And our friends at GNI have really pioneered this, but opportunities to follow that patient from the EMS stretcher down to CT, and if they're going to an interventional suite, up to the interventional suite, and seeing that will change, that will obviously, while that's a life-changing event for the patient, it is an education-changing event for the EMS provider as well. Our friends at GNI pioneered that, at least in this area, and I can't thank you enough for doing that. So looking to the future, we talked a little bit about the telemedicine piece and how we have different apps among different healthcare systems, and it's kind of challenging to make sure we're using the right one. We're about to trial right here at Gloucester County EMS, and I'm proud to tell you this, you're the first folks that we've talked about this with. We have a new function, or will have a new function, where when somebody calls 911 from a smartphone, our dispatcher is going to be able to send them in a text message a link, and the link is platform agnostic. And when the caller clicks on that link, it'll allow the caller to live stream video back to dispatch. And dispatch can now send that same link to, for instance, one of my responding crews. So my responding crew on their way to the call can actually see what's going on there. We can send that same link, dispatch can send that same link to an ED doc or a neurologist on call, so we could link the patient to the specialist before we ever left the scene. So imagine, again, what potentially the improvements in outcome could be if I can take and link that patient to that specialist before the patient ever left their home or before the patient ever left there. I mean, imagine the possibilities for that. That's just, from our standpoint, that truly is true telemedicine. And again, it's platform agnostic, it's HIPAA compliant, it's secure. So we're really, really excited about that. And hopefully, maybe a year from now, I can come back and let everybody know how successful that program was. So that's all I've got. We're coming up on the end of it. So I just want to thank you so much for letting me spend part of my morning with you. I hope it's not pouring where you're at. I hope that I've provided some information for you. So thank you.
Thank you very much. That was fantastic. So you know, this was one of our most popular grand rounds to date. We had a great turnout and a great registration for it. So it was information that people really were curious about and wanted to learn more about. So we have just a couple minutes, and I guess a couple questions that came in when you were talking about the destination of getting to the hospital. What is there anything from a patient advocate point of view that a patient can do to direct where that goes, or is that something that's entirely in your purview because you have the right of way?
No, and now I can only speak for this agency because every other agencies will have other policies. Our goal is always to take the patient to the most appropriate facility. So we have folks every day who present to us with medical presentations that are currently being followed by a facility in Philadelphia. And if they're well enough and it's related to that, we will absolutely take them to that facility in Philadelphia, regardless of call volume. The only patient that matters is the guy who's on my stretcher at that moment. Likewise, we have some kids within our coverage area that have pretty complicated medical conditions. So we go to DuPont almost every day, and we certainly go to CHOP on a very, very frequent basis each week. The only time we'll override that is if a patient or a family member is trying to direct us to an inappropriate destination. So they want us to take a burn patient to the community hospital. We'll explain to them why we can't do that, why it's not in the patient's best interest. And 99.999% of the time, that patient or that patient's family jumps on board and understands that.
Sure.
Same thing with trauma. We'll take trauma patients to trauma centers, not to community hospitals. If worse comes to worse, and again, out of 35,000 calls, this may happen once or twice a year, we'll certainly reach out to medical command and get some input from medical command and put the medical command physician on directly with the family to explain why we need to take them to a different facility. Same thing, a STEMI patient we're going to take to someplace that has an interventional cath lab.
And then I guess from before it even gets to the point where you have to go to a hospital, is there anything that we can do to teach our patients of what would help them should they need to call EMS? Like what should they have on hand, like a little go bag, if you will, of what would make your life easier?
So we offer a function, and many other EMS agencies. So as much as I'd like to take credit for this, we were not the originator of this. We have what's called a file, F-I-L-E, of life, which is a document that sits in a magnetic envelope that you put onto your door, your refrigerator, and it contains all of your medical history, and most importantly, it contains your up-to-date medications and up-to-date allergies, so that if you're unable to tell us that, we know to go look at your refrigerator door. We can pull that off your refrigerator door and take that with us. While certainly family members will often gather and hand us what we refer to as the bag o' meds, which is all of that patient's prescription medications. We're always afraid, candidly, that that gets lost in the shuffle someplace, and then in no way intentionally, but whether it gets balled up in the linen between EMS transferred to ED or ED going upstairs. And you have to recognize from the patient's standpoint, the out-of-pocket cost for that group of medications. So that's why we'd much rather we'd much rather take that information in on a piece of paper. And dosages and frequency are also recorded on there, so it becomes very easy to hand that off to the next caregiver in line.
We appreciated your talk. That was fantastic and very informative. For those that joined, thank you all so much for attending. This was recorded and will be available on our website for review. And have a great rest of your day.
And again, sincerely, thank you
much.
all on behalf of our patients on what you do for them. We truly, truly appreciate that. Thank you.
Of course. Bye-bye.